All right. Hello. I'm Matt Steliga, a thoracic surgeon at the University of Arkansas, and I'm honored to share with you a little bit of information about how smoking cessation matters and ways to help patients quit. So, why are we here? Well, if we look at the STS mission on the web page, it says it right there. We are here to improve the lives of patients with cardiothoracic diseases. And yeah, we focus a lot on improving the lives with surgery and operations that are very complex and challenging, but there's small, simple things that can be worked into our workflow that can also improve patients' lives. So our mission is to improve their lives overall, but we know that ongoing tobacco use directly opposes that mission. Patients who continue to smoke have worse outcomes, and once they get through their surgical treatment and recovery, their ongoing health issues are at further risk of cardiovascular disease and further risk of cancer from second primary tumors. So cessation impacts quality of life and outcomes, both in the short term and long term. Okay, it's important, great, but can we really make a difference? Yes, surgeons can make a difference in a couple different ways. Brief advice is important, and physician words matter to patients. And indirectly, we are in charge of programs. People look to us for guidance and structure, and we can help include some of these metrics or some of these measures into our workflow and patient care. So why does it matter? Okay. So in this study, there's 224 lung cancer patients, and look at the split in those survival curves. That Kaplan-Meier graph shows differences in survival and is not based on chemotherapy, radiotherapy, or other treatments. The difference in survival is those who quit smoking and those who continue to smoke. And so 9 months survival may not sound like a lot, but 9 months survival, a lot of drugs and other therapies and treatments get approved for much less than that. And smoking cessation overall is cost effective and easily a beneficial thing for all patients who smoke. This was a study from colleagues in St. Louis who looked at over 7,000 surgical patients, lung cancer, in the VA system. And persistent smoking 1 year after surgery had significantly shorter overall survival. Patients who continue to smoke had worse outcomes, and those who were able to quit had better survival. Interestingly, it was not disease-free survival, but overall survival. So that suggests that their ongoing smoking has a host of other problems related to respiratory infections, cardiovascular disease, and other non-oncologically related outcomes. Uh, So, counseling framework, how do we get people to quit smoking? There is incredible amounts of work and effort done on this by some very, very dedicated experts in smoking cessation. But a framework that's commonly used is the 5 A's, where we ask every patient about their tobacco, advise them to quit, assess their willingness, assist them to quit, and arrange some follow-up. But this requires time, expertise, and follow-up, and lots of effort. I don't know about everyone else, but my clinic is usually packed and doesn't always run on time, and I may not have time for this. So a framework that is much easier to work into your clinical schedule and workflow is ask and advise and refer. It's important that people ask, otherwise we don't know if they're using tobacco or not. And advice should come from a physician. Physician advice matters. Um, Without any advice or cessation support, quit rates are in very low single digits, but physician advice can boost that by several percent. But refer is important because this takes some of the heavy lifting, some of the details, and some of the real expertise in cessation strategies with the counseling and the medications, and that outsources that to experts who know how to do it better than we do and who are more effective and who have more time and energy. Some places are fortunate to have in-house resources. We've built a great program here at the University of Arkansas, and I have some incredible colleagues that help us with that. Other people in your programs may not have that in your system, but there may be things in your community, through other groups, American Lung Association, American Heart Association. Smoking cessation programs are in many communities, and you can look for those and refer to them. And every state in our country and most countries around the world have toll-free quit numbers, and those can be used to help patients as well. So ask, advise, and refer is our preferred strategy. We provide the care at the point of care where the patient comes to see us in the clinic. It's an opt-out strategy, meaning that it is provided to the patient unless they decline it and say no, thank you. And it's led by a nurse practitioner who has extensive training and expertise in this area. So, our own institutional experience, we first started with an opt in, phrasing it with, hey, would you like to talk to somebody? Many patients, given the option, might say no. So, we reframed it with, this is part of your treatment program. And while you're waiting to see the doctor, someone's going to visit with you. Now, they could always decline that, and they had that ability. But nearly 95% of people accepted the counseling, and it worked. It was led by nurse practitioners. It was at the point of care right there in the clinic where the patient was visiting and waiting for the surgeons. And it was delivered with follow up plans, counseling, and medications. And we verified some of our quit rates with exhaled breath carbon monoxide monitoring. It's a handheld device that can easily show if somebody has ongoing use or not. So, what did we learn from this? Well, our first few years, our lung screening patients, uh, over 90% were able to be counseled. Some of them couldn't because of travel issues or the way the schedule aligned, but most of them were able to be counseled. And we had a nearly 13% quit rate. Now, that doesn't sound that impressive, but 1 out of 8 people quitting smoking who's got a 20 to 30 pack year or more history and unable to quit before, that's great. We were very happy with that. In clinic, we had even higher quit rates of people who were facing upcoming surgery. So we were able to provide the counseling at a place where the patient was, and it was well accepted by patients, and it worked. So, a few take home messages here. It is never too late to quit. Any patient can benefit from quitting smoking, regardless of if they are pre op or ongoing surveillance. Your words matter. It takes only a few seconds to tell patients. It's an incredibly important part of our treatment plan for you to quit smoking. I want you to work with someone and help us give you the best chances of getting through surgery safely. Your leadership matters in your program. People turn to us for all kinds of advice about how to structure programs. And if we continue to push for integrating this necessary resource in our cancer treatment programs and cardiovascular treatment programs, our leadership can make a difference. And finally, cessation at its core aligns with our mission as individuals and our mission as a society. So thank you. There's some contact information from me. I appreciate the ability to share this with you.